Who'd like to kick off? Yes, Mohammed. Okay, question there.
Well, it's more of a helicopter view to what I've observed today. So I would like to ask, the first question is that there were few principles or ideas being used as they were de facto. For example, the mirror neurons. So as far as I know, there's only one study in humans. It was done in 1999 by Marco Iacoboni, who's a friend of mine, and that's it. There isn't really anything that can prove conclusively that the mirror neurons exist in any functional way, and everything else was extrapolation from bolt signals and MRI. So the question I have regarding this one is, when you have a new field coming in that is evolutionary psychiatry, you're trying to build something on some sort of basis, you run the risk of using principles that themselves are not founded. The other problem I have is with hypothesis testing. So let's say that I want to test any of the hypotheses that have been presented today, and we could generate many of them. Then we're going to go back to populations that want to study in them. The question is, are we going to go back to the DSM-5, for example, to use those people as the target population, or there's a system that you would recommend by which these hypotheses should be tested?
Anyone like to take that on? Martin.
I would like to respond to the mirror neuron question. The difficulty is that you can't put electrodes in human brains, so you can't examine neurons or mirror neuron systems directly. But there is a fairly nice neurophysiological window which suggests that the activity in a certain EEG band, the alpha band, is a correlate of mirror neuron activity. So we use that method to study mirror neuron, whatever it is, activity in people with schizophrenia and also in people with borderline personality disorder. And the findings were quite disappointing, or at least, in fact, showing that the mirror neuron system is not at the core of these kinds of psychopathologies, because the mirror neuron system worked quite well both in people with schizophrenia and in people with borderline personality disorder. So we found very little differences in mu rhythm suppression, as it is called, the physiological correlate you find in the EEG. So, but it's interesting, and I think also necessary to take paradigms from basic science and try to import them into clinical neuroscience. So that was the idea behind that research.
George, next.
I wanted to bring what you've been talking about very much more towards the clinical cold phase. And I wanted to ask you a little bit about, where does evolutionary psychiatry fit within the spectrum of theories of psychiatry? And more specifically, the treatments we have, whether they be biological or psychological. We now have a range of treatments: CBT, IPT, mentalization therapy. What is the relationship of the formulations you have with these existing therapies? For example, the knowledge that Professor Brunet told us about, what does this add or take away from mentalization therapy in personality disorders? In your case, Professor Gilbert, what is the relation with interpersonal therapy, for example? So could you integrate what you're saying with the field as it is?
You mean compassion?
Yes, correct. Yeah.
Okay, so I think, yeah, so that's great. Tricky one. So a lot of the psychological therapies are really focused on ways of engaging with clients. So you have things like, free association or Socratic questioning or challenging negative thoughts or behavioral rehearsal, whatever it is. And they tend to be, what Alfonso was saying this morning, they tend to be orientated toward a symptom or hypothetical constructs such as negative schemas or whatever it is. What we're trying to do in evolutionary approaches to psychopathology is to identify the underlying evolved motivational system and its physiological infrastructures that have to be addressed if you're going to produce change. So the way you produce change, you may well do behavioral rehearsal, blah, blah, all that stuff. But what you're trying to do is to get into a system that evolution suggests to you is a way of which the mind is organized. So the thing is that a motivational system will organize a whole lot of things. So you don't want to pick them off one by one. You want to get into that system. So I don't know what Martin thinks about this. So our view is that if you can get into this caring system, then that has a whole range of impacts. The way you do it may well be to use cognitive techniques or behavioral techniques. So what my evolutionary psychiatry colleagues and others are doing are trying to think about. So how do we identify those systems? In what way does the polymorphings on genes influence how those systems are working? I think because in the future psychological therapies are going to be much more tailored towards phenotypic patterns, not just symptoms. So, I don't know if that helps at all, but I try to get into this underlying evolved system that organizes cognition, behavior, and attention, and so on.
Riyad, you've got this microphone handy.
Thank you. We are in the process of trying to persuade the college to include in the study of evolution as part of the curriculum for postgraduate training. So can I ask each of the three speakers, what would be, from their point of view, a persuasive reason why the college should consider this?
What advice would you give us to tell the college?
Perhaps I could say something. I noticed with some alarm that research papers now, perhaps it's obligatory because I don't put in for grants or anything, to say how useful this piece of research is going to be. I deplore this tendency. I think knowledge in itself and understanding of the human condition is important. And I think there's more than one reason for being a psychiatrist. I think we help people, we hope to help people, we hope to be compassionate and to relieve suffering. But we also hope, I think, I do, to understand better the human condition, which is one of the reasons we do any of the intellectual things we do. So a very influential figure for me was the unjustly not well-known John Cutting, psychiatrist, who is probably too philosophically minded to hit the mainstream, but he said, I think, a rather brilliant thing. Medicine is a branch of psychiatry, which I think is a very, very good observation, because in essence, whenever you are seeing a patient with whatever, you are seeing whatever you're getting reflected through the personality and life of that person. So you said, medicine is a branch of psychiatry, and psychiatry is a branch of philosophy, and I think that is absolutely correct. So I don't think...
How does that help us with selling evolution?
I can't help you sell anything. I've never been able to sell anything in my life.
Please, yes.
I think Alfonso has told us why it is necessary. I think one misconception is that evolution is a slow process and has nothing to say with regard to therapy. This is wrong. And I think this is the most important reason to implement evolutionary issues in training, to show that it has consequences for treatment. Yeah, I think, isn't that enough?
I mean,
So you can deliver better treatments if you think in evolutionary perspectives at both levels, psychotherapeutic and, say, biological psychopharmaceutical treatment.
Yes, we briefly go back to the thing. Look, we can study brains and we can see when people are depressed, the dopamine's down or the cortisol is up or whatever it is. But what we don't know is, why would the brain do that? Why is it just an abnormality is what it is? Well, the thing that people like John and Bowlby and these evolutionary people did is said, look, your brain is designed that in this context, if you get defeated or if you get abandoned, okay, as an infant, your brain will respond this way. It's designed to do that. Okay, it's not just an abnormality, it's designed to do that. So that gives us a platform of understanding what is the brain designed to do in certain contexts related to certain genetic profile. And the next thing, I think, which is really the elephant in the room, is we do need to talk about human needs. We need to talk about the psychological nutrients that humans need throughout their lives in order to function at their optimum. Okay, and that is really to do with interpersonal relating. So those two things I think I would support.
Okay. There's a lady who's been waiting some time over there, and Paul, I have seen you. I'll come back to you afterwards.
I've been working in community team adult psychiatry, and it seems that there's a lot of patients are diagnosed with borderline personality disorder, where the differential diagnosis may be PTSD, depression, adjustment disorders. And I'd like to ask the team whether they think that the move of society, this is working or not. Is it not working?
Very close. You have to be very close to it.
Oh, I see. Sorry. Anyway, the question is, there's been a cultural move to independence where we are asked to take responsibility for our own actions. And I'm asking whether or not you think that has resulted in an increase in the diagnosis of borderline personality disorder. And also, whether the medicalisation of adjustment disorder has also resulted in an increase in that diagnosis.
An increased?
Increase in the diagnosis.
Right.
Okay, so there's two parts to that.
Yeah. I'm asking why you think borderline personality disorder, why the diagnosis has evolved and increased.
Why it has increased?
Yes.
I mean, do we know that it has increased?
Yeah. It certainly has in our trust.
I mean, even with autism, which is I think somewhat clearer, there's very strong evidence that it's more diagnosed but not more common. I mean, we don't know, but I mean, I think somebody earlier said something about the importance of victimhood, and I think we live in a society where it's more and more attractive, and borderlines are super queens, thespians who are extremely good at attracting all kinds of positive emotions through being victims.
Yes, I mean,
very powerful.
Yeah, one of the things I would say, I don't know if you know Sue Hari's book, Mothers and Others. Now, she makes a really interesting point that the natural environment for children is extended families, right? Where men don't play that much of a role. It's all to do with kin, sisters and aunties and uncles. So children. So the point is, if you had one parent who wasn't particularly good, they would compensate by being brought up by grandmother, auntie, whatever it is. This idea of children trapped in a house, so there isn't any other carer apart from that parent who's dysfunctional. This is abnormal, grossly abnormal. Yeah. So that's a mismatch. So the child doesn't have any other options for finding caring from a sister or an auntie or whatever it is. So I think this is quite important. Many of these children are trapped. A friend of mine, just one story, a friend of mine, when she was my PhD student, actually was living in a bedsit in Nottingham, and the person next door was a single parent mum who used to scream at the children pretty much all the time, fuck you, fuck you, fuck you. So she called in the social services, and the social services, well, they're not, we're not actually hearing this and blah, 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 blah. So they didn't do anything. But I mean, the point is that those children had nowhere else to go. They were totally trapped with this poor woman who was obviously losing it. And there was no evidence of sexual, physical abuse. She just used to shout at them. But that's the point. How can we help people have options for finding caring others?
Paul.
Could I just mention three things, as I'm the editor of the newsletter. Somebody asked, I think you asked about how do we test evolutionary hypotheses. Well, the first thing is there's a lot of articles in the newsletters about that, but better than anything I've written is Randy Ness's website, and it's got 10 questions for evolutionary psychologists or psychiatrists. There are ways of doing it, but yes, we can't go back in Doctor Who's TARDIS and watch brain development in a population or gene changes. Of course we can't. The second thing is, why evolutionary psychiatry? plugging myself a little bit, there's the first talk on the website looks at why we're doing this. And that leads into I know we've got to go in a minute because we're running out of time. The reason we do it is this cross-fertilization and looking at what it means to be human and where humans have come from and why we have these genes. And I just want to thank the panel and all the other speakers today for the most fantastic day of multidisciplinary, multi-axial views of things, which is why we do evolutionary psychiatry. It's not just evolution, it's about all the other things around it. So thank you, guys.
Thank you, Paul. One last question for the panel.
Yes.
A question for Professor Gilbert. Most of the pathology you describe, borderline personality disorder, attachment problems, I see in heroin addicts, and to a certain extent in alcoholics. Would the compassion-focused therapy approach have any evidence base in treating addictions?
It's a wonderful question. To some degree, yes. One of the problems that we have, and I think Martin's mentioned this, is to get money for proper RCTs. It's really, really difficult. I mean, we have put in for grants, and you're always in the poverty trap. We don't have enough evidence for us to. Yeah, but that's why we want the money, to get the evidence, right? So we've got a little bit of a problem. There's a lot of anecdotal evidence, and there are a number of clinics around the country that are using CFT to very good effect. But in terms of a full-blown RCT, there isn't one even on the horizon at the moment, but there's a lot of anecdotal evidence. We have a list called the Compassionate Mind List, where people share all their stories about, how they've been using CFT and changing it for this population and that population. There's people doing it with dementia and learning difficulties and things. But yes, the CFT does quite well with people with drug and alcohol addictions.
Thank you very much.
Along with the other therapies. It's not we call it compassion-focused therapy. So you focus your therapy. All of the other things that are necessary, like exposure or response prevention, you still have to do all of that stuff as well.
Well, time, I think, has got the better of us. So I feel that we've had a really fascinating afternoon here, and it makes one think of the directions in which this group can go, that there are so many possibilities and so much scope for development about understanding the nature of ourselves, how we are going to look after those people whose minds are affected when we don't even know properly how the mind works in the first place. There's a vast amount of work to be done, many, many lifetimes of work to be done, but it's wonderful to have such erudite talks today, giving us some inspiration for hope that we can make progress in the future. And so on your behalf, could we all thank the three speakers here today, or this afternoon, and also all the speakers from this morning as well, for a wonderful session.